Right. I want to ask you gentlemen a question. I'm Larry Perlman. I'm a clinical psychologist. I'm in private practice.
Put the mic near your mouth.
I'm Larry Perlman, clinical psychologist. I'm in private practice in Ann Arbor, and I was formerly at the VA hospital and on the faculty at the University of Michigan in the Department of Psychiatry. Question came up at lunch. There are, in the private practice community, it is virtually impossible to find somebody, a psychiatrist who takes insurance reimbursements, who's on the panels. And this has been a source of frustration for those of us who want to refer and collaborate with a psychiatrist. Do you have an answer to this? I know Blue Cross is concerned about it because I'm on the insurance committee of the State Psychological Association. But I'm just wondering if this is something that's discussed in the societies or within the universities. And there was a young psychiatrist who finished a residency program a year ago and started a practice and took insurance reimbursements, and within 4 months he stopped doing it. It was too much of a hassle for him, too much extra administrative work. So you guys have a response to that. Thank you.
All right, well, I'll start, and again, I think I got the microphone in the right place, but if it's not right, let me know. You have asked the perfectly wrong guy. I was on the faculty of the University of Michigan my whole career, and billing and insurance were somebody else's problem. They paid me a salary and kept all the rest. I can't really answer for private practice. I think one thing that happens is that it's not just that they do or don't take insurance, but you can fill up your practice and then you just don't take anybody. Well, you slowly take people as people leave your practice. But one of the problems is that people soon after residency, if they're good and or lucky, will fill their hours, and I think that's part of the problem.
Right, I concur with Dr. Cameron. So I too have never been in private practice. Was at the university for a while, and now kind of in the public sector with our community mental health system, which focuses on serving people who have Medicaid or who do not have health insurance. But it does feel like a problem to me because one of the other things I do is work with primary care doctors in a safety net clinic, a clinic that serves people who are uninsured or underinsured. And it is difficult to find private psychiatrists for people who are new to insurance. At least this is what we are discovering these days. With Medicaid expansion, the Healthy Michigan Plan, fantastic thing that people have health insurance. And there is a mental health and substance abuse treatment benefit with Healthy Michigan, which is fantastic. And all of the managed care providers for those Medicaid insurance plans do have people on panel, if you kind of look at the lists that we see, that we try to refer people to. But that doesn't mean it's easy to get in. The phrase phantom panel has come up multiple times. And what I'm hearing from some of my colleagues is that sometimes there's a 3-month wait or a 6-month wait, or, oh no, the list wasn't quite right. And I know at this point we have some people who are kind of coming off of hospitalizations for mental health reasons who are going to primary care docs, actually, because it's sometimes difficult to find a psychiatrist in the community. What is the answer to this conundrum? I'm not sure, but I think it's the right question. And I know the Michigan Psychiatric Society has identified that as an issue.
Yeah, I guess I would make a couple of additional observations. First of all, as much of a problem as it undoubtedly is for you, it's far worse if you go way outstate. One of the issues, I'm involved with a number of boards that do advocacy and so on, and there's a lot of talk and a lot of disagreement about, well, should we give psychologists more prescribing privileges? Should we allow nurses a more free practice to be on their own? And there's a whole list of those kinds of things that come up. And part of me, and don't quote me, although the room's full of people who can quote me, you know, I'm not supposed to think that those folks should be allowed to have more practice and so on. But if you're realistic, you look at that and you say, wait a minute, you know, we've got to figure out a way to deliver services to an adequate number of people. So, you know, on my little left shoulder, the angel's saying, oh, let them do more. You know, we should oversee them, but let them do more. So, but on my right shoulder, if you look at the map of the distribution of people of all stripes who are doing mental health, they're all in the same place. So if tomorrow we said, all right, we'll let all those people who want to prescribe certain kinds of psychotropic medicines prescribe them, there would still be a massive shortage in the Upper Peninsula. There would still be a massive shortage in Gaylord, et cetera, et cetera. So it's not clear that that's really a solution. And I say this in part because, you know, I look around the room and I know, at least in the seminar session we had just before lunch, there was a number of students in there. You know, not everybody practices in Washtenaw County or in Oakland County. And as much of a problem as it is, it's even harder the farther you get away from the academic and the urban centers.
Yeah. Telepsychiatry has taken off. So there are opportunities for more rural areas to contract with behavioral health providers from places where there is a high density of them, and actually have an opportunity to, I believe, do some billing now. So that is at least one push in the right direction for those folks.
My name is Hubert Hubel, and I'm a retired surgeon, so in this field I'm a layperson. And my question for you is, somebody who is now in their late 40s, who's been chronically depressed over years, difficult to treat, my son, becomes delusional and paranoid delusional over the last couple of years. Why would that be? And that just happened under treatment, under medications. The second aspect of it is, what can be done? Can he recover?
Well, excuse me. The first thing, you know, in my bio it says I do so-called psychosomatic medicine. Psychosomatic medicine these days, among other things, is really the practice on the interface between medicine and psychiatry. A lot of that is in the somewhat older population. Now, I don't know how old your son is. I suspect, I'm sorry?
49.
Okay, he's a little young for this, but I guess I'll make this general statement anyway. One of the things that we are learning is that mental illness makes medical illness worse, and medical illness makes mental illness worse. And particularly if you're developing some kind of cognitive difficulty, it's going to make the mental illness look worse. So one question that I would ask is he sure, or are you sure, that the other aspects of his health care are optimally managed? In other words, is he having, because he's old enough to begin to be in this age range, is he, and because of his background with the chronic mental illness, which makes him more susceptible, are you sure he's not having any cognitive difficulties that would contribute to that? Secondly, are you sure that he's not having any heart disease or anything like that might contribute? Is he getting sicker in other ways? That could make it worse. The other question I would have is, has he had the full panoply of treatments? There's probably a broad range of opinion in this room about whether ECT is the angel or the devil of the world. I understand that. But for someone who is truly delusional, if they haven't had ECT, they should. Now, I don't know if he hasn't, I'm not asking, but I would just suggest that. You know, I'll tell you, if I had a delusional depression, I'd have ECT.
I would too. Just to take that in a slightly different direction as well and not talk about any specific individual, but it's also the case that there's a natural history, a progression of illness with many of our mental health conditions. And so separate from this specific case, you know, for things like recurrent major depression, bipolar disorder, schizophrenia, there can be a progression in illness, even severity, without treatment. So one of the things, you know, we're always interested in partnering with NAMI with is really education. And education in this regard for recurrent depression means get treatment, and if you've had multiple episodes, it's important to stay on something that can keep you from having the next episode, because episodes over time can become deeper, longer, and more difficult to treat. If I had depression with any break from reality, any kind of symptom that we call psychosis, hallucinations, fixed false beliefs, delusions, I'd go for ECT. The response rate is remarkably good for that specific illness and for many other things for which other treatments have not been successful. So, you know, one other place to always think about looking locally is, you know, what other resources are there? I was actually talking to someone this morning at the side of a soccer field, a guy who's a psychiatrist, who happens to be in the treatment refractory depression clinic at the University of Michigan. So in addition to ECT, there are other modalities, other types of biological treatments available now, including he's involved with transcranial magnetic stimulation. It's another way to affect how the brain works when other kinds of treatments aren't working. So, you know, I would just end with hope. There's still hope. And it's always good to keep looking for, you know, what other opportunities are there as well.
Hi, I'm Michael. I'm wondering what is both of your attitudes towards family members when they come in, if they come in to talk about their loved one. What would you kind of want, what kind of information would you want to have from them? And on the flip side of that, if the mentally ill person is willing, what do you kind of feel any the desire to sort of tell them something, or their responsibility to kind of tell them something?
I am a big fan of information. If I'm a clinician working with an individual, I need to get a lot of information from the person I'm working with. It's also helpful to have collateral information from other people, from loved ones, who are involved with the person that I am attempting to care for, to, as much as possible, round out the picture, which helps me kind of with diagnoses, but also with treatment. So sharing information that I'll usually start with an open-ended question, you know, tell me what you think is relevant. What's going on? You know, what are you seeing? Just so that I can start to then ask some follow-up questions. The other part of that is that a social support network is treatment. Medicines are treatment, therapies are treatment. Having some social cohesion and being part of a connectedness to others is treatment. You know, one of the things we've kind of learned over a number of years in the public sector of mental health is that morbidity, problems functioning in life, and even death, dying earlier than the general population, increases for people who don't have social cohesion, family networks. So I do think that's important. In any way we as clinicians can partner with that network, I think that really can be helpful. It's kind of a broad answer. You got any other specifics?
Yeah, the other thing I would add, particularly if I'm dealing with a younger person and I can meet with older family members, they will sometimes know family history that the patient, him or herself, doesn't know. Now, in some situations, that is not necessary. You know, you look at the patient, you know what's wrong, et cetera, et cetera. But particularly when there's diagnostic mysteries or when there's therapeutic mysteries, knowing that Uncle Charlie had this history of all these crazy high periods, pardon the word crazy, but that's what the word you often hear from family members. They'll talk about stuff like that. There was odd Uncle Charlie, and Uncle Charlie really got sick for 3 months, and then he seemed to come out of it. And then 2 years later, the same thing happened again. Well, that smells of a bipolar pattern, and although you don't necessarily know that for sure, when you're trying to figure out what's wrong with the patient that you're dealing with, to know that there's this family history, which the patient can't tell you because the patient doesn't know it, can sometimes be helpful. Also, treatment's the same thing. These are not ironclad rules, but if somebody says to me, you know, my brother had bipolar disorder and lithium has done wonders for him, lithium might or might not be the first thing I would choose to treat knowing nothing else. But if you got a brother with bipolar disorder who's responded to lithium, you get lithium unless you can convince me not to give it to you. Period.
Mm-hmm.
My name is Pat. Hi, thanks for being here. Out in the hallway there are some tables with pamphlets and from other agencies and things like that. And I noticed that at the U of M, for the U of M Depression Center, one of the flyers is for support groups. And they all specify, whether it's for family or people living with, that they're for depression or bipolar, and schizophrenia is not mentioned any place. Now I know it's called the Depression Center, and maybe that's the answer to the question, but I wonder if there's another explanation for that. Thank you.
I don't think I have one beyond the one that you've already detected. I'm old enough to remember very well when the University of Michigan had an active schizophrenia program too that looked kind of similar. It wasn't as big as the Depression Center, but it was certainly there. For various reasons, in a world of constricted resources, you know, sometimes you put more of your eggs in this basket and some few of your eggs in that basket. And right now, because of the pendulum swing, they're doing, you know, they have this depression center and they've got a lot of their eggs in that basket. But I suspect community mental health would have more resources in the schizophrenia side.
Yeah, so I can't speak directly to why the university may or may not be preferentially, you know, focusing on one health condition kind of more than another. It is true on the community mental health side, serving individuals with schizophrenia is quite common. And there are some opportunities for family to be involved in some of those treatment efforts. One kind of initiative involves multi-family groups. Actually, the university partnered with us for that for a little while, especially for people with first break episodes. Unfortunately, for individuals who are not served by the community mental health center, those kind of treatment groups are not available. When it comes to other kind of support groups, you know, we actually look to the community for a number of other kinds of supports as well. What are some of the things out there now? Do we still have the Manic Depression and Depressive Association groups, or
Depression and bipolar
Carmel?
support lines.
Depression, thank you, Professor Powell. Depression and bipolar support line. Carmela?
Schizophrenics Anonymous.
Absolutely. Schizophrenics Anonymous. What else we got out there? Let's source them out.
Fresh start.
Fresh Start.
Hearing Voices Network meets every month and asks for people that either hear voices or have unusual experiences that might be defined as psychosis, and we just support each other. And sometimes it's helpful because maybe community mental health might not have time to deal with everything that we want to deal with, but we can support each other with that. There's also Pathways to Recovery on Mondays from 3:30 to 5. Everyone's welcome with any diagnosis or without a diagnosis, whatever. And peer supports help people.
And also NAMI offers a couple of support groups on the same night so that families can go and those with diagnosis can go to the with diagnosis support groups, and the family members can go to the, in support of.
I mean, I guess a point I would make, which I think is being emphasized by all the comments here, is that you have to look to the larger community rather than just St. Joe's or just CMH or just the U of M or just NAMI. You know, it's the whole panoply of activities. It takes a mental health community to cover the waterfront.
Thank you.
Hi, my name is James, and I have a number of family I take care of. And he has schizophrenia, about 40 years diagnosed. The life expectancy of the literature is 65. And what can I do to make sure I can make sure that the issues that may occur would not occur? And what things I can do to limit that would occur to benefit his in a way that's progressive and we have a longer life.
Could you repeat the question? We are able to hear it all.
Is that microphone turned on?
Well, let me try, and you correct me if I don't paraphrase it correctly. This gentleman referred to one of his family members who's had a schizophrenia for many years. He's now a little younger than I am, and he has a family concern about what can he do to optimize this person's life expectancy and enjoyment for life for the remaining years.
Yes.
Is that fair enough?
What they say a lot of the medications he's had over the years will cause a lot of damage in his health, and I've noticed, I think that's probably what is occurring, and it is occurring, may actually be occurring now. And I'd like to minimize that without reducing medications to a certain level that affects his psychosis and things, but yet doesn't help his health decline. So it's a really difficult balancing act. And I'm trying to figure out what do I do to make sure that I can do that well.
Right. That's a great question. It's a great question. There's a group in Wisconsin that runs a program sponsored by Robert Wood Johnson Foundation. It's the help me, Mark. County. There's a group in Wisconsin that ranks the health of counties around the country. And they've also kind of posted on their website, and I apologize, I can't remember the exact name of the group, the County Health Roadmap Group or something along those lines, just kind of breaking down what kind of big chunk areas cause problems with life expectancy or not being able to fully enjoy life along the way if you have a in the general population. I do think a lot of what they're finding is relevant to people with schizophrenia and mental illnesses, other than schizophrenia as well. And they kind of break it down this way. Let me say that about 20% of the problem is access to medical services and high-quality medical services. So working to get people into good care, to screen for medical conditions, to then treat medical conditions is really important. About 30% involves health risk behaviors, the decisions that we each make every day that may not necessarily be in our best interest. So it's things like, do you smoke cigarettes? Do you like to go to 7-Eleven and get the big gulp of sugar water if you might have diabetes or be gaining weight? Other nutritional choices, alcohol, and working to modify or address health risk behaviors when it comes to morbidity and mortality stuff matters, it appears, as much as getting that care from the medical community. So for that group, one of the things we're working on at CSTS, we had an opportunity to have a grant from SAMHSA, the Substance Abuse and Mental Health Services Administration, that just ended. We had it for about 4 years. And gave us an opportunity to try to roll in some health risk modifying activities into our agency. So we've been, trying to do groups that involve peers in groups, nurses in groups, working on smoking cessation, nutrition, exercise, all framed in a way that the goal is not to frame it in a way of you must do. So instead of doing 2 or doing 4, the goal is to kind of do with and get people to activate. So the goal is to kind of motivate, to engage people around some of these activities. So for us it's been food, tobacco, exercise. We have peers that go out to grocery stores with people to read labels to try to get a sense for how do we make different kinds of choices. But it kind of needs to start with the person kind of wanting to do that. So health risk behaviors are really important. Another aspect of it, 40% are what they would call social determinants of health. And some of the things that factor out is we all need housing. We all need optimally stable housing. We need an environment that is clean. We need some kind of resources so that we have, a little bit of income does help, however that comes about. And then we need people. We're people, and people need people. So that social cohesion piece. So they broke it down, 40% social determinants like the housing and the income and social relatedness. 30% health risk behaviors. 20% getting in to see high quality medical providers. It's really the expectation, not the exception, that people with schizophrenia or bipolar disorder, recurrent major depression, have co-occurring medical conditions. And they all have their own natural history that you don't want to happen. Like if you have diabetes, you want to try to catch it early. You want to stay on top of it. Because if you don't, some of the organs in your body can get damaged, potentially permanently. So it all kind of rolls in together in that regard. Other stuff.
Yeah, well, I endorse everything that's said, and I would like to underscore a couple of things. First of all, to the extent that you do find perhaps medical problems are occurring, improving those will also improve, at least theoretically, the management of the psychiatric illness, and vice versa. The medical and the psychiatric illnesses interact with each other, so that whichever one you've got, if you've got them both, whichever one is primary is going to make the other one worse, and it works in both directions. So, if the person's diabetic and they're having more depression, treat the diabetes. It's good for their medical condition. It's also good for their depression. And treat their depression, and it's good for their diabetes. And not only because depressed people sometimes don't behave well in taking care of themselves, but from a biological point of view, treating each one seems to help the other. The other thing I would say, which may be a little counterintuitive, but I'm getting to an age where I think about this for myself. I believe that the quality of life is more important than the quantity. Don't make your brother absolutely miserable trying to get him to do all the things that you know he should do. You know, stop smoking. Stop bugging me. I won't stop smoking. You know, nobody would ever endorse telling someone to keep smoking. But be realistic. Be realistic about what can be expected. If he's on antipsychotic medications, they're going to make weight control hard. You know, someone's 40 pounds overweight, maybe he can only lose 15 pounds, but that's progress. And, you know, to make him lose 40 pounds might make him so miserable that he can't do anything else. His smoking goes up from a pack a day to 2.5 packs a day. You know, you just have to be very realistic about this. And as I say, there's a certain equation here, and quality and quantity of life can sometimes, you know, they're kind of like this sometimes, and you gotta know that.
Mm-hmm. Yeah, I mean, recovery is all about what? Striving for your hopes, dreams, and ambitions with whatever comes at you. And, you know, if there's some quality that, you know, if you want to, I don't know, you can pick any activity that is particularly enjoyable, you know, there's often a trade-off off with that.
You can only eat so much rabbit food in any 1 week.
That's right, and I can only switch to decaf for so long.
We've got another question.
Hi, I'm Kristen through Westmont Community College nursing student, and we've done a lot of talking about throughout the day about approaching or intervening with someone who has a mental illness or anything like that. I have a family member, severe depression, bipolar, attempted suicide 4 times, but she is seeking treatment. What I'm asking is her family, how she's seeking treatment, she's accepted it, how can I go about, or somebody go about, explaining to the family or getting their family to realize this is more serious than they think, because they get angry with her easily. They don't want their kids around her, and realize that she's managing, but getting her family to realize there's more to it than just she tried killing herself.
Well, thanks. He gives me all the easy questions. I guess the first thing I would ask, is, are you sure, and I assume from the way you asked the question that the answer is yes, but are you sure that you know how much the patient wants his or her family involved? But assuming that that has been resolved and the person does want the family involved and informed and so on, I guess the first thing I would do is I would find out, you know, without trying to get into any kind of arm wrestle, is the family informed? I mean, you know, you're going to find some people who will just say, I don't believe in mental illness. Maybe you can change their mind, maybe you can't, but most people are not quite at that extreme. You know, the first thing that I think would be important is to make sure, have they ever heard of bipolar illness? You know, have they watched the crazy TV shows where everybody and their brother and their sister-in-law have bipolar illness? I mean, it seems like it's more common than dental caries if you watch TV. But out there amidst all this overdiagnosis and drama and so on, there are some people out there who really have a very serious illness. Do they know that? Do they believe it? Do they know what bipolar illness is? You know, are they informed? And that would be where I would start. And then once I was fairly convinced that all the major players in the family were informed, then I would kind of recalibrate, you know, now what do they think about this person? Do they now still think that he or she is not as sick as they want you to believe they are? Or are they beginning to get it? And I think that would be my first step. And then I would go from there.
Mm-hmm. I think that's a great place to start. Yeah, you know, some people, I don't know in this particular case, but, you know, I hear from some folks who say, my family just doesn't get that this is an issue. You know, how do I talk to them about it? And, you know, sometimes those family members will go to doctors for medical problems, but mental health is this other kind of taboo topic. So we sometimes Even medicalizing the mental health condition helps. The brain is an organ in the body like any other organ, and it can get sick. You know, lungs wheeze. If you have asthma and your lungs are wheezing, it messes with life. You can't walk up the stairs, you know, certainly can't, you know, go for a long run. You treat it, you don't have symptoms, you function better. Pancreases get sick, they don't make insulin. You get diabetes. You treat it, blood sugars come down, people feel better, they function better. Brains get sick too. They can get depressed, depression messes with life. You treat it, you can function better. Sometimes that kind of approach can sometimes help for some people as well. The other thing we found is that not a lot of people, some people who feel personally kind of that stigma of mental illness from people around them or communities or won't come to psychiatry, but they will go to that primary care doc, which is also why we're kind of big fans of trying to get the medical community more actively engaged and knowledgeable about treating mental health conditions. So, you know, one of the big pushes nationally is for integrated care. So, kind of one-stop shopping, or at least going one place, and that place can be the hub from which all of your health care can flow. So that's why we now have, you know, psychiatrists like me hanging out in primary care offices with social workers from the community mental health center. And also why we have medical nurses working in our community mental health center to treat medical things on the mental health side. And there's many different ways to skin that cat. But, you know, connecting to some professional somewhere in the system and then kind of working backwards to getting the rest of the issues addressed can sometimes be helpful for some.
Don't forget, one other issue is that NAMI offers a great class called Family to Family to help families understand, turn the light bulb on. If they know nothing about it and they're afraid of it or they're ignoring it because they don't understand it, this class will give them insight.
We've got time for one more question. Back here.
I'm a internal medicine doctor, and I work with psychiatrists trying to optimize the general health of psychiatric patients. And to address what the gentleman asked earlier, I have to say that just like in all the other communities, there's discrimination against psychiatric patients among doctors and healthcare providers. So I'm ashamed to say that, but it's true. And what I would do is I would urge family members of patients with mental illness to be a really strong advocate for getting the same screenings and treatment that everyone else gets. Just for example, colonoscopies at age 50 or earlier. I've encountered so many cases of my patients who've got no screening, no attempted screening, and they're 59, 64, and the providers just don't take it seriously as they should. Not all of them, but too many of them. The same with cardiac screening, diabetes, making sure that they don't have diabetes. There's a real tendency among some healthcare providers to just treat the mental illness as, you know, they look at you as a person with mental illness and then everything else just sort of drops off. So you really have to be demanding sometimes and insist that your family member gets a colonoscopy, assuming that they're willing to do it and want it, like everyone else.
We all want a colonoscopy.
Yes. And also a lot of as you guys mentioned, the antipsychotics and antidepressants cause a lot of other problems, like lithium and kidney dysfunction, monitoring levels of lithium and valproic acid. If you don't monitor those levels, patients can become toxic, and you don't even know what's going on, but their mental health suffers as a result. So anyway, be demanding and ask questions and be polite when you do it, but stand firm.
You know, I was just going to reiterate what Jim was saying. You know, I think there was a time that all of us didn't understand mental illness. And most people don't understand it, family members especially, until they've had to go through this journey. And we have this 12-week class, and we have family members come, so it could be siblings or spouses or significant others, and they take this class, and in 12 weeks you can see this transformation, because knowledge is power. And once people really understand that this is a brain illness, and they get it, all of a sudden they become empathetic, and they realize that symptoms are not willful behavior. But I think all of us at one time thought that, and so education and knowledge is the key.
Could I just add one thing? In response to your question back there about how to bring family members in, sometimes the family members or the friends will see the psychiatric care community as having their own axe to grind. I mean, you wouldn't be in this business if you didn't blah, blah, blah. Sometimes you need what looks like, and perhaps is, a more disinterested advocate for convincing the family member that this is real and serious. And apropos of what was just said from the internal medicine doc in the back, if you have an understanding primary care doctor or an understanding internist who doesn't look like he or she ought to have an axe to grind to convince you that your brother has bipolar disorder, you can hear it a little less defensively from that person. Or maybe a family member's gone through the 12-week program and now they're convinced, and now maybe they can become an advocate to get other family members to hear it. So in other words, you have to gang up on them with the facts, and sometimes those facts have to come from what looks like a disinterested neutral party rather than someone who is working that mental health side of the street, so to speak.
Well, ladies and gentlemen, we have to bring this segment to a close. And I just want to acknowledge and give appreciation, round of applause for pinch hitting.